is Brennan Hardy. Today, I will be discussing the differences in clinical efficacy and patient outcomes between two treatment methods for obstructive sleep apnea: upper airway stimulation therapy and traditional CPAP. Furthermore, a prospective research design will be proposed to more effectively appraise these differences. So first and foremost, it would be helpful to begin with an explanation as to what exactly obstructive sleep apnea is. The disorder is characterized by two hallmark respiratory events: episodes of apneas, which are intermittent periods with absence of breathing during sleep for at least 10 seconds in length, and hypopneas, which are reductions in the breathing amplitude during sleep for at least 10 seconds in length as well. In other words, apneas occur when complete upper airway obstruction is present, as the patient will stop breathing completely. Conversely, hypopneas will occur when partial upper airway obstruction is present, as the patient's breathing will become shallower and more reduced, but still be present. However, both apneas and hypopneas are associated with oxygen desaturation, or a decrease in the patient's blood oxygen levels during sleep, which can ultimately induce numerous health complications if OSA is left untreated. OSA is one of the most diagnosed sleep-related disorders of breathing within the United States, and this is exemplified by an increasing prevalence of 15% in males and 5% in females across our population. Lastly, for diagnostic purposes, the severity of OSA is often assessed by subjective and objective evaluations. Two of the most common evaluations performed include the Epworth Sleepiness Scale and Apnea-Hypopnea Index, with the latter requiring an overnight sleep study to calculate. As these two measurements are imperative to a research proposal, it is crucial that we review these OSA evaluation methods to provide further context. Subjective evaluations that aid in measuring how patients perceive OSA's impact on their quality of life are often found in the form of sleep questionnaires or scales that are completed by the patients themselves. One of the most common subjective scales implemented throughout sleep clinics is the Epworth Sleepiness Scale, abbreviated as ESS, which tasks the patient with subjectively scoring a total of 8 questions on a scale from 0 to 3. This is designed to quantify a patient's level of daytime sleepiness, where a score of 0 indicates that a patient would never doze off during the activity specified within one of the 8 questions. A score of 1 indicates mild chance of dozing. A score of 2 indicates moderate chance of dozing off, and a score of 3 indicates that there is a high chance that the patient would doze off during the activity in question. When all 8 questions are totaled, a score of 0 to 5 is considered normal, 6 to 10 would be attributable to mild daytime sleepiness, 11 to 17 is considered moderate daytime sleepiness, and 18 to 24 is associated with severe daytime sleepiness. Thus, a higher Epworth Sleepiness Scale score equates to more daytime sleepiness and worsened quality of life as perceived by the patient. Conversely, the primary objective evaluation utilized to quantify OSA severity is the Apnea-Hypopnea Index, or AHI, which represents the average number of apneas and hypopneas that occur per hour of sleep attained by the patient. As previously stated, the only way to calculate AHI is by subjecting the patient to an overnight sleep study, which is otherwise known as a polysomnogram, abbreviated as PSG. Mild OSA is characterized by an AHI of greater than or equal to 5 and less than 15, moderate OSA by an AHI of greater than or equal to 15 and less than 30, and severe OSA by an AHI of greater than or equal to 30. Therefore, a higher AHI value equates to more severe OSA. In order to calculate AHI, we first count the total apneas and hypopneas that occurred during an overnight study in total. Afterwards, we divide this total count by the total sleep time that was achieved by the patient in minutes, and multiplying this end product by 60 to revert the value back from minutes to hours, we conclude with our resulting AHI. Again, for further context, an explanation as to what exactly CPAP is warranted. Continuous positive airway pressure, or CPAP therapy, employs the use of a machine with an internal compressor to generate pressurized room air. A common misconception is that CPAP provides supplemental oxygen above what we breathe in naturally. This is not the case, although supplemental oxygen may be added to the system in accordance with the prescribed oxygen leader flow. The generated air pressure then delivers purified air to the upper airway via a tubing system that is connected to a mask interface. Common mask interface designs include nasal pillows, which fit up underneath each nostril exclusively, nasal masks, which fit over the nose itself, and oronasal, otherwise known as full-face masks, which are implemented to fit over both the nose and mouth to allow for mouth breathing. While mask interface selection is largely dependent upon patient preference, there are many nuances with regards to how patients initially respond to CPAP, as there is no one-size-fits-all approach to optimizing therapy and an inherent lack of a universal mask interface that will fit every patient. Despite this, the overall mechanism of action as to how CPAP therapy works to treat OSA is akin to a pneumatic stent. The pressurized air that is delivered through the mask interface pneumatically stents open the patient's upper airway to resolve apneic episodes during sleep. OSA has been traditionally treated with CPAP therapy, which is universally determined as the gold standard therapeutic modality for moderate to severe OSA. In contrast to traditional CPAP therapy, upper airway stimulation, which is more colloquially known as hypoglossal nerve stimulation therapy due to its mechanism of action, requires an invasive surgical implantation akin to a pacemaker. This surgical procedure involves the placement of an implantable pulse generator, or IPG, unilaterally, or on one side of the body within the infraclavicular space of the chest. The IPG is designed to deliver an electrical stimulus to the stimulation cuff electrode that is placed upon hypoglossal nerve fibers. A breathing sensor is also surgically inserted into the inspiratory intercostal muscles of the chest to coordinate electrical stimulation with the patient's breathing cycle. In doing so, when inspiration is sensed, the IPG is prompted from this breathing sensor to produce an electrical stimulus to be delivered to the hypoglossal nerve to produce upper airway stimulation and thereby opening to resolve obstructive sleep apnea. The hypoglossal nerve itself is relevant, as it innervates the intrinsic and extrinsic muscles of the tongue. Decreased muscle tone of the tongue that occurs during sleep naturally is a factor that influences upper airway collapse in some obstructive sleep apnea patients. Therefore, this system of electrical stimulation through the hypoglossal nerve produces tongue muscle actions that are necessary to reduce the role of the tongue in causing upper airway obstruction, and thus OSA. The clinical effectiveness of this therapy is largely dependent upon the ability for the IPG to produce an electrical stimulus to the hypoglossal nerve fibers that innervate the tongue muscles that produce both tongue protrusion and stiffening, thereby opening the upper airway. We also want to avoid the fibers that innervate tongue muscles that promote tongue retraction, thereby preventing upper airway closure. As a result, it is crucial that the surgeon places the stimulation cuff electrode on the hypoglossal nerve fibers that selectively innervate the genioglossus, transverse, and verticalis muscles for therapy optimization. Lastly, in being FDA approved since 2014, hypoglossal nerve stimulation therapy first requires candidates to undergo drug-induced sleep endoscopy, or DISE, to evaluate the degree and type of airway collapse that is present. Candidates must also retain moderate to severe OSA and a BMI of less than or equal to 32. As CPAP is still considered the first-line gold standard treatment method for OSA, patients are often required to have a previous failure in attempting to adhere or acclimate to CPAP therapy as well. Alternative treatment options or methods are typically not explored until CPAP is at least attempted, although each patient's circumstance is different. While traditional CPAP is still noted as the gold standard treatment option for obstructive sleep apnea, and despite advancements made in CPAP therapy over the years in terms of design as well as comfort, as much as 50 to 60% of patients within one study were noted as being unlikely to adhere to long-term CPAP therapy. Other sources have reported that only approximately 70% of CPAP-naive patients, or first-time CPAP users, will continue regular use of therapy after only 1 year. Based on the clinical definition of compliance to therapy within the United States from the Centers for Medicare and Medicaid Services of greater than or equal to 4 hours of use for greater than or equal to 70% of nights, adherence rates were found to be extremely variable from 29 to 83%, and adherence to CPAP often decreases significantly after this 1 year period. Similarly, 46 to 83% of patients have expressed overall non-compliance with CPAP therapy, despite the medical necessity of adherence to treatment. To make matters worse, as many patients are unable to tolerate treatment, untreated OSA poses a tangible, hidden threat to society. In fact, cases of untreated moderate to severe OSA have actually been linked to a multitude of comorbidities, including clinical depression, hypertension, cardiac disease or failure, acute myocardial infarction, stroke, and type 2 diabetes. Overall, the estimated economic burden of undiagnosed, and therefore untreated, OSA was approximately $150 billion in 2015. This includes $6.5 billion attributed to workplace incidents, $26.2 billion in relation to motor vehicle accidents, $86.9 billion towards lost productivity at work, and $30 billion via comorbid conditions. Thus, while the reasons maintained for avoiding the use of CPAP are multifactorial and complex, they are nonetheless significant and require solutions. In order to diminish the societal and economic impact that untreated OSA continues to retain, patients must be optimally treated and compliant with that treatment regimen. As so many patients are unable to tolerate CPAP and are therefore unable to become nightly users of this therapy, alternative methods in sleep therapeutics must be explored. So the specific aim of this research proposal shall be to explore the differences in clinical outcomes between CPAP and upper airway stimulation therapies within a cohort of patients diagnosed with obstructive sleep apnea. In short, this proposed study encompasses a prospective, single-center, case-control design that will be implemented at a local health facility that retains both a surgical and sleep center. 100 participants will be enrolled and separated into 2 case groups. 50 participants will receive traditional CPAP for treatment of OSA, while the other 50 participants will undergo surgical implantation of upper airway stimulation at the local surgical center. Upon separating the total pool of subjects into 2 case groups, 2 overnight sleep studies are to be performed at the local sleep center for each participant. The first sleep study will take place as a baseline measurement of their obstructive sleep apnea, or how severe their obstructive sleep apnea is pre-treatment. The second sleep study is to take place following 2 weeks of regular, nightly treatment of each participant's obstructive sleep apnea, whether via CPAP or upper airway stimulation. The goal of the second sleep study is to quantify how those receiving CPAP responded to therapy versus those receiving upper airway stimulation. A 5-point scaled satisfaction survey will also be conducted following the second sleep study to determine the mean satisfaction rate of the treatment method that was used. The central independent variable will be the type of therapy selected by the participant, whether that be CPAP or upper airway stimulation. 3 measurements will act as the dependent variables and include 1. The mean change in AHI from baseline to follow-up polysomnogram, indicating resolution of OSA. 2. The mean change in Epworth Sleepiness Scale scores from baseline to follow-up polysomnogram, indicating resolution of daytime sleepiness, or the subjective symptoms of obstructive sleep apnea. And number 3, the mean satisfaction score of the treatment utilized, suggesting how likely it is that the average patient would continue compliant use of that particular treatment method. Inclusion criteria was chosen to reflect current FDA guidelines established to approve patients for upper airway stimulation use, and stipulates, for those participants placed into the upper airway stimulation cohort, the requirement of a previous failure in attempting CPAP. In pursuing this research design, I hope to answer 4 distinct research questions. The first three of these questions shall be answered via a direct comparison of the baseline and post-treatment sleep studies across both case groups. In doing so, it will be determined as to which case group proved most clinically effective in terms of reduced OSA severity and symptoms. The cure rate, which is the ratio of participants that experience completely cured or resolved obstructive sleep apnea, as defined by an AHI of less than 5 during the post-treatment sleep study, will also be compared across both treatment methods. Lastly, a comparison of the mean satisfaction rate of the treatment method used will assist in theorizing the average patient's willingness to continue compliance with the therapy that was selected by the patient. To my knowledge, no research has exclusively investigated the differences in overall satisfaction between CPAP and upper airway stimulation therapies or directly compared the two. Therefore, this proposed research will surely fulfill this knowledge gap and facilitate a better understanding of the treatment option that patients would be most likely to adhere to and utilize. Based on the historical precedent identified within the literature, we expect three primary findings from this proposed research design. First and foremost, as it is considered a universal gold standard practice for the treatment of OSA, it is to be expected that CPAP therapy would significantly improve the participants' presentation of obstructive sleep apnea. Therefore, it is hypothesized that this study will conclude with what is already known within the literature, that CPAP is a viable, effective treatment option for those that are able to tolerate it. Secondly, it is to be expected that upper airway stimulation would provide comparable benefits in resolving participants' OSA. It is hypothesized that upper airway stimulation would, at the very least, demonstrate similar reductions in mean AHI and Epworth Sleepiness Scale scores during the second overnight sleep study following treatment. This is supported within the literature, as the ADHERE registry involving 301 subjects demonstrated a reduction in mean AHI from 35.6 to 10.2, and mean Epworth Sleepiness Scale score from 11.9 to 7.5 from pre to post-treatment. In fact, upper airway stimulation therapy has been found amongst other studies to reduce the baseline pre-treatment AHI by a clinically significant margin of 68%, and in some studies as high as 90%. At minimum, it is posited that upper airway stimulation therapy implemented within our study would be efficacious enough to be considered a surgical success as defined within the literature. In other words, we expect upper airway stimulation to at least reduce the mean AHI to less than 20, while maintaining a greater than or equal to 50% reduction in AHI from the baseline measurement taken during the first overnight sleep study. The final dependent variable examined, mean satisfaction rate, would be compared between the CPAP and upper airway stimulation cohorts. This variable is expected to retain the highest degree of discrepancy between these two cohorts. It is hypothesized that the mean satisfaction of upper airway stimulation would be twofold greater than that recorded amongst participants receiving CPAP. This is, again, supported within the literature via the ADHERE registry and a larger registry consisting of a pool of 501 subjects. 90% of subjects within the ADHERE registry reported more satisfaction with upper airway stimulation in comparison to their previous use of CPAP. Additionally, 96% of subjects within the larger registry reported that upper airway stimulation was better than they had recalled their prior experience with CPAP. Thus, it is to be expected that upper airway stimulation would maintain greater satisfaction and subsequently superior adherence rates amongst participants in direct comparison to those receiving CPAP. Obstructive sleep apnea is a hidden health crisis that retains global implications, as the global incidence of those affected by this disorder is approximately 1 billion individuals, with the incidence rate exceeding 50% of the population in some countries. Thus, this global crisis requires global solutions to the issue at hand: untreated OSA. The consequences of allowing a population with OSA to be subjected to suboptimal treatment, such as CPAP therapy if patients are unwilling to comply with regular nightly use, are far-reaching. Firstly, medical institutions will be impacted via the multitude of health complications attributable to untreated OSA. In fact, a fourfold increased risk for mortality has been expressed and reported within the literature in individuals affected by untreated, moderate to severe OSA. Our societal systems are also impacted, as those suffering from untreated OSA are considerably more likely to be responsible for motor vehicle accidents and lost productivity at work. An estimated $100.1 billion in annual savings could occur within the United States by optimally treating every adult diagnosed with obstructive sleep apnea. So it is critical that innovative treatment options that promote compliance continue to be developed and introduced within sleep medicine. As issues with CPAP therapy adherence are ongoing amongst its users, sleep medicine innovations, such as the Inspire implantable device to administer upper airway stimulation therapy, must be viewed as a practical, primary treatment option for obstructive sleep apnea. Upper airway stimulation has retained a more optimal satisfaction rate amongst its users in comparison to traditional CPAP, with only a minute number of adverse events reported. As a society, we must strive for sleep medicine innovations that will enable a patient population that is both satisfied and adequately compliant with their OSA treatment. Possible limitations of this proposed study are inherent in its design, as a smaller sample of only 100 participants is not really representative of the U.S. population in its entirety. In addition, a single-center study reduces the occurrence of external input from other centers or institutions. In this regard, a single-center study may recruit too few participants and lack the scientific consistency that is more apparent within multi-center trials. Lastly, we report one conflict of interest due to employment and monetary compensation at this single health facility. Our conclusions are twofold. First, notwithstanding the known clinical efficacy of CPAP, the desired health outcomes of a therapeutic method are unfortunately limited by the patient's tolerance to the therapy. In other words, if a patient is unable or unwilling to tolerate CPAP, its reported effectiveness retains no real clinical significance. A treatment method for obstructive sleep apnea is only as effective as the patient's tolerance level will allow. Secondly, due to the widely recognized variance in adherence rates for CPAP, it is our position that an alternative method that can retain similar effectiveness, yet improved adherence, should be at the forefront of treatment options for obstructive sleep apnea. We propose that, in cases where a failure to acclimate to CPAP occurs, upper airway stimulation should take precedence as a primary treatment option. The following are my references for this project and research proposal. Thank you so much for watching.